A very good morning to all of you, and you're joining with the Continuous Professional Development Program organized by the Shri Society for Health Research and Innovations. So, starting with beginning your attention to the few rules keeping first, please note the presentation will be recorded throughout, and therefore you're kindly requested to keep your mics muted and videos switched off for better quality of transmission. The webinar will be open, available from 9 a.m. to 9:50 a.m. for you to join in. And please note that late attendees will not be entertained thereafter. And each attendee should be present till the end of the webinar to obtain the certificate for CPD points. The CPD points are strictly adhered to the National Committee on Continuing Professional Development Guidelines. So this is to improve and maintain the standards of CPD programs conducted by the Shri and can for the strict adherence to CPD regulations and your kind compliance. We would like to move on to information about asking questions at the end of the webinar. So if you have any questions, please feel free to type it in the chat box, and please make sure that you change your chat settings to all panelists and attendees so that your questions can be answered at the end of the session. So if you have any specific questions, please feel free to email us on the email address given in the presentation here. So we would like to move on to today's topic. So before we move on to this, Dr. Shanmuganathan and Swarnan, who would be the guest speaker for today. He's a consultant general surgeon with special interest in lower GI surgery, who is currently working at the base hospital of Kalawanchikudi. And he has obtained his MBBS, that is Bachelorate in Medicine and Surgery. And he's an elite alumni from the Faculty of Medicine. He has completed his MD Surgery, and he's also a membership of the Royal College of Surgeons in both Edinburgh and Glasgow. And Dr. Swarnan has been awarded the fellowship in the Minimal Access Surgery in India. Today, he would be talking to us about a very timely topic on the unveiling the mystery, understanding colorectal bleeding, and what you need to know. So, over to you, sir.
So, good morning, everyone, and thank you for joining me in this timely topic. Seems colorectal bleeding and what you need to know. Yes. So, you see the commode full of blood. Okay. So, it's very scary, right? So you can see the commode, blood, and a few blood clots. As we all are medical professionals, we know something about colorectal bleeding. However, whether we medical professionals or non-medical professionals, if we see blood during the defecation or after defecation, it's really scary. It will make lots of anxiety. It's very unpleasant feeling. First thought that would come to our mind is whether it is a full-blown colorectal carcinoma. So it happens to everyone, irrelevant to the education level or age. So first of all, we'll go through a few cases. How can we tackle here? First one, 23-year-old mother who is 30 weeks pregnant and has intermittent fresh blood bleeding, PR bleeding, without any concomitant red flag signs or symptoms. On examination, just in inspection, found to have third-degree hemorrhoid. It's not a hemorrhage, it's a hemorrhoid. And next question is, does she need additional treatment or any part is missing in the examination? We will go through one by one later on after the presentation. Second one, 30-year-old manual labor had minimal fresh bleeding for 1 or 2 months duration, no blood clots during bowel movements, no discomfort, no pain, no family history, and no family history of colorectal carcinoma. DRE was normal. So, is this patient need any sort of further investigation, or can we manage over the counter, or can we manage OPD level, or in general practice? We'll see that later. The third one, 25-year-old female student, presented with fresh PR bleeding along with excruciating pain. It lasts for about 30 minutes even after the defecation. Blood is also seen coating the stool after bowel movement. Does she need DRE? Does she need any sort of endoscopy? So we'll see that later. This is 56-year-old male patient. It has no additional symptoms and normal DRE showed up with a fresh PRP. His second incident having occurred maybe 1 or 2 months prior. He is not on any blood thinners. So what is next? What we can do for him next? Fifth case, 67-year-old man with intermittent PR bleed that were fresh and mixed with stool. Also reported weight loss and the feeling of insufficient evacuation. Not using any blood thinners, but having third-degree hemorrhoid. What we can do next? The introduction. Definitely, we have all normally come across at least one patient, at least once in 2 weeks or once in 3 weeks time, especially in the general practice. Patient will come and tell us PR bleeding. Whether the bleed is torrential bleeding or whether the patient is having a blood stained stool or drops of blood, that depends. That depends on the patients. It's definitely it's a very scary feeling to the patient. Patient definitely come to us and tell PR bleeding what to do next. So rectal bleeding or rectal bleeding or bleeding per rectum, there are different terminologies. It also we can tell the patient, yes, of course, we have the PR bleeding. We will go through step by step, history, examination. If needed, we can go ahead with the investigation. It depends. So by definition, PR bleeding also can be known as, we can tell as hematochezia. It is referred as hematochezia as well. So rectal bleeding refers to the passage of blood through the anus, usually seen during the bowel movement. But the melena is somewhat different. Melena also a GI bleeding inside our GI tract, but it happens more proximally. It presents as a PR bleeding, but not as a fresh blood. It is tarry or black stool. It's bleeding from the upper GI, and at least 50 ml of blood is needed to make the stool in black in color. Okay, so melena may continue for up to 5 days following the cessation of the bleeding. So if a patient presents the melena or tarry blood or black color stool, it means a patient has had an acute bleeding within 4 or 5 days time, or maybe the patient's bleeding, or maybe the bleeding has stopped 2 or 3 days before, but maybe 4 to 5 days within that period. So if the patient comes with the melena, we have to monitor the patient, and maybe inward or outpatient manner, depends on the patient's age and the presentation and the past history. We have to monitor the patient at least for 5 days. Fine. Rectal bleeding, by saying, it can be broadly classified in 2 categories. One is patient can present with minimal bright red blood per rectum. It's a minimal blood. Intermittently, patient notices. And it may be present for about 2-3 days, and then 3-4 days it's absent, and again patient notices that blood in the stool. It's a minimal per rectal bleeding. One. Those patients most of the time present to the OPD or clinic or to the general practice. But the second category is a scary one. It is acute lower GI bleeding. It means patient open bowel for blood. Patient feels the urgency. Patient feels that patient wants to go to the toilet, and patient goes and opens the bowel. Is blood with stool or lots of blood clots, pouring of blood, and 2-3 times a day. It lasts for about 2-3 days, and scary, and patient straight away come to the A&E. So this patient definitely ends up to the A&E, not to the OPD or a clinic or a general practice. So these patients are coming to the A&E, and then these patients should be managed inwardly. So the patient is safe here because patient will be anyway admitted to the hospital. So in our topic today, we'll see the first one, minimal bright red bleeding per rectum, not the acute lower GI bleeding. So rectal bleeding is a very common symptom in adults, sorry, adults for all ages, range from benign to serious underlying conditions. Fortunately, in most people, it is intermittent and often self-limiting. The majority of them are benign in their conditions, so most of them are safe. The majority of patients seek advice because, as I have told earlier, they are concerned that the bleeding indicates something serious. So they think, is it a cancer? Right. This is anatomy we all know, well familiar to this anatomy. First picture shows the rectum and the anus. We all know the anatomy of the rectum is designed to store the blood. Sorry, store the stool. Okay. So by having said that, if a bleeding from the anus for any reason, straight away just come out of the GI tract. So during the defecation, the bleeding from the anus, there's no way of storing inside, there's no way of staying inside. It will come out with the stool. So definitely the anal bleeding for any reason will present as fresh blood. So during the defecation, patient might feel fresh drops of blood dropping after the defecation, at the end of the defecation or before the defecation, some spurt of blood, or the stool is spurted with fresh blood. So that's very easy to narrow down our diagnosis. But the proximal to that, rectal bleeding, for any reason, if it's can present as a fresh blood or blood clots or mixed with blood or slightly altered blood. Why? Because the blood inside the rectum can stay for hours with the stool and can come out as a blood. Okay. So by looking at the color, exactly we can tell where the bleeding source is. Right. That's about the rectum. And if you go more proximally, the left colon also can present as a fresh blood or blood mixed with stool. And right colon, most of the time, normally they don't present with the fresh PR bleeding per se. They normally present with the anemic symptoms, occult bleeding. If the tumor is bigger or some angiodysplasia or any bleeding source is massive, patient can present with fresh blood. If you go more proximally, say small bowel or the esophagus or stomach or duodenum, that blood normally they do not present as a fresh blood here because it will take long time to pass from the upper GI to lower GI and rectum and anus. So it will take long time. So the blood goes into various changes and the color changes and it will come as a direct blood. Unless if there's a torrential bleeding in the upper GI, lots of blood in the upper GI, it can quickly pass through and come as a fresh blood as well to the anus. Right. Slightly we touch about this acute lower GI bleeding as well. So commonest cause is diverticulosis. Fortunately, in our country, in Sri Lanka, diverticular disease is very uncommon. It's rare, but not like in the Western world. In the UK, diverticulosis, diverticulitis, and its complications are very common, irrespective of age. Even 25, 30-year-old patient will come with the diverticular perforation, strictures, all the complications. So almost 40% of acute GI bleeding in Western world is diverticulosis. Or any ischemic pathology, ischemic colitis, or ischemic small bowel or large bowel. Rectal pathology as well also will come as a acute bleeding, lower GI bleeding, and we'll see it later. And cancers, obviously it's a cancer. Wherever the cancer is, if it is bleeding profusely, it can present as a acute lower GI bleeding. And we know arteriovenous malformations, angiodysplasia. It can happen anywhere in our GI tract, it can present as a bleeding. And post-polypectomy patients, sometimes endoscopically, we do the polypectomy, and it can cause various symptoms. One is that bleeding can present as a bleeding, it can be managed later. And IBD, obviously IBD. It also carries 2 to 4%. But IBD also is very, very less occurrence in our country. Inflammatory bowel disease can be Crohn's disease or ulcerative colitis. And radiation colitis or radiation proctitis can also lead to blood per rectum. Okay. And the other important thing we should not forget, bleeding PR, fresh blood, also can come from the upper GI, not we do expect that upper GI bleeding always come as melena type, but not like that. That the upper GI bleeding, upper GI in a sense, the esophagus, stomach, and the duodenum, proximal to the ligament of Treitz. It also can present as a fresh PR bleeding if there's a massive torrential bleeding in the upper GI. Okay, right. So this is a bit of a busy slide. I don't know whether you can appreciate this one here. Fine. I'll quickly tell you. This is about acute lower GI bleeding, not the minimal per rectal bleeding. Okay. If an acute lower GI bleeding, in a sense, patient opens bowel for blood. If the patient comes to the A&E, normally the patient doesn't come to the general practice or OPD or a clinic. Straight away, patient will come to the A&E. So how can I tackle that patient? This is not a topic today, but anyway, I'll just touch it, okay? Anyway, patient's bleeding. We don't know, of course. Or maybe patient have had some sort of a past history as well. First thing is to see whether the patient is stable or unstable. In a sense, hemodynamically stable or hemodynamically unstable. What's the purpose of management, or what is the goal of treatment here? To stabilize the patient first. And if we can identify the source and stop bleeding, and treat the cause or the whatever the definitive treatment is, that's not the discussion here. So stop the bleeding is a problem here, right? Fine. So if the patient is hemodynamically stable, so what is hemodynamically stable is a different topic. If the patient is hemodynamically stable, okay, we can proceed for the investigation. If the patient is hemodynamically unstable, we have to resuscitate the patient. We all know, hand-in-hand resuscitation, and make the patient stabilize. If the patient is stabilized, okay. Still, if the patient is unstable, then it's a different algorithm. If the patient's hemodynamic is stable, fresh PR bleeding, first we think about the low GI bleeding, then we think about the upper GI bleeding, right? So we can attempt for the colonoscopy. The only problem is bowel is not prepared. Bowel is full of blood and blood clots. Therefore, doing colonoscopy also tricky here. It should be done by a very skilled, experienced consultant, right? Fine. Say if you are doing the colonoscopy, because patient is stable, and if you can find the source, fine, we can treat. When the bleeding source is fine, okay, we can do the endotherapy to stop the bleeding first. Then we can go for the definitive treatment. If we can't find the source of bleeding, next thing we should think about, something is bleeding from upper GI, right? So we can go for an OGD. If we can't find both, something should bleed still if the patient is bleeding, something from the small bowel, okay? So during the endoscopy is difficult. In that case, we can think about doing the CT angiogram, okay? And that's about the stable patient. If it's an unstable patient, first line of intervention is the OGD. OGD in a sense, upper GI endoscopy first. At the first instance, we have to go for an OGD, thinking that that is the source of bleeding. And if we can find the bleeding, that's fine. We can go ahead. If not, next thing is to go for a CT angiogram, because patient is unstable. We can't go for a colonoscopy. CT angiogram, we can find the source of bleeding because patient is still bleeding. That's the reason patient is unstable. So if the patient is still bleeding, and then that's indicated for a CT angiogram, we can find the source of bleeding. And then we can go for interventional radiology interventions like, embolization, or we can find the source of bleeding. We can go with any intervention. So that's about the acute lower GI bleeding. And we'll move on. Right, we'll come back to the minimal rectal bleeding or normal PR bleeding, right? The common causes of PR bleeding, okay? The age age of the patient acts as a guide to the range of potential causes of rectal bleeding. For example, younger patients under the age of 30 are more likely to have hemorrhoids, anal fissures, some inflammatory bowel disease, or some perianal or anal conditions. That's very common. But there can be some sinister pathology, but this is the common. If the patient is over 50, the rectal bleeding can have, we should always think about some sort of a bad pathology like colorectal carcinoma. We'll see later on. So the presence of anorectal pathology does not preclude other proximal colorectal pathologies. Okay, it's very important. It means if there's the patient presenting with PR bleeding, and first thing we all see we do the DRE. Okay, we have found there's a hemorrhoid. There's obvious patients bleeding in there, but it doesn't mean that patient doesn't have a sinister pathology proximal to that area. Okay, so presence of hemorrhoid does not exclude a more proximal cultic lesion, and could even mask the concomitant bleeding for neoplastic lesion. There are various, I can tell the number of incidents happen just seeing the hemorrhoid, treating the hemorrhoid day by end, weeks and months, and the patient missing some proximal lesions, some patient end up with metastatic rectal carcinoma, and young patients and patient end up with the APR with the later stage and failing treatment. So we should always think about if there are no hemorrhoid, it's fine, it's bleeding, but always we should think and we should exclude proximal pathology. That's about hemorrhoid. And the anal fissure, we all know, we'll see what it is. And rectal polyps also can present with the bleeding and minimal bleeding, and at the end of the defecation, patient can have bleeding or mixed blood mixed with stools. Diverticulosis, yes, that we talked about, that's very uncommon here, but still it can happen. There are some instances in Sri Lanka as well, patients have diverticulitis disease, diverticulosis. That's the dangerous part. If the diverticular disease starts to bleed, it will be torrential and life-threatening bleeding, right? And obviously the colorectal carcinoma and inflammatory bowel disease, right? Having said that, the perectal bleeding, even though we say it's a blood or it's a bleeding, the color may be in different, like, it can be a bright red, fresh bright red, or dark blood, altered in color, or the melanina is not in the discussion here. It's melanina also perectal bleeding, but it's in different scenario. So the patient come with the blood seen in the commode or the toilet tissue, tell the blood. But we had to go step by step to identify what sort of bleeding is and where can be the source of bleeding. Okay. Important thing is we should always ask about the blood volume, color, and how it is associated to the stool and any associated other symptoms. Okay, like pain, altered bowel habit, family history, loss of weight, loss of appetite. That's a lot of history taking part in for the colorectal carcinoma. Right. We see the hemorrhoid. Hemorrhoid is one of the most common benign pathology for minimal PR bleeding. I'm dead sure all of you have come across such patients. They do come at least once a week to the general practice with the PR bleeding young patients. And if you take the proper history, definitely should be the pathology behind it is the hemorrhoid. Okay, so there are two things. Most of us that we misinterpret that. Two hemorrhoids. One is an internal hemorrhoid and external hemorrhoid. Internal hemorrhoid, in a sense, the cushion, the venous cushion, artery venous cushion, which lies inside to the dentate line, and it swells and it comes through the veins. That's the internal hemorrhoid. The external hemorrhoid is, you can see here, the cushion is outside the dentate line and is almost at the anal verge, and it is covered by the skin. That is external hemorrhoid. Okay, so it doesn't mean that if a hemorrhoid is coming from inside and it splats outside and maybe thrombosed, then we can't label as it's a thrombosed external hemorrhoid. thrombus external hemorrhage is totally different. Okay, so we'll talk about the internal hemorrhoid first. Internal hemorrhoid can be graded in grade 1 to 3. 1 and 2, 1 and 2 can be managed at the OPD level or in the general practice. 3 and 4 better refer to a specialist care center. 1, basically, patient have minimal blood or irritation. That's it. We can't see any sort of a hemorrhoid or the piles outside, or we can't feel anything by DRE. 2, the pile is coming out during the defecation and it goes in on its own. Okay. For this one also, patient will tell that PR bleeding, and sometimes the patient may feel the lump at the anus, but during the DRE you can't see any lump. During the DRE inside, you can't palpate any lump unless if it is thrombosed. Remember, hemorrhoids, first and secondary hemorrhoids, we can't feel by DRE. By doing the DRE, we can't tell it's hemorrhoid. By doing the DRE, we can't tell it, oh yes, the first degree hemorrhoid or secondary hemorrhoid. Unless if it is thrombosed only, we can feel it. Third and fourth is, of course, it can be noticed in the outside. It's because it's a prolapsed one. Third one is collapsing, and patient itself can put it inside. Fourth is a prolapsed and a huge hemorrhoid. Patient can't put it inside. Definitely, patient come to the hospital and get admitted, and we can manage the patient. Okay, so hemorrhoid normally present with painless bleeding during the defecation. It must be a fresh blood because it's in the anal verge, and it may coat the stool, or there's a drop of blood after defecation or spurt of blood before the defecation. Okay, it's bright in color. It can't, most of the time, it can't be altered blood. Still, if there's internal hemorrhoids bleeding inside the rectum and stays for about an hour and becoming the stool, it can come as altered blood, but it's not a common scenario. If the hemorrhoid is causing pain, in a sense, that is thrombus. So pain due to thrombosis is a different presentation. In that case, we have to manage the patient, maybe in work or as an outpatient. This is about the fissure. The second commonest cause for fresh minimal PR bleeding is the fissure in ANO or the perianal fissure. Fissure is a different type of presentation. For the young adults, it's really annoying, not like hemorrhoids, right? There's a tear just distal to the dentate line in the mucocutaneous junction, or distal to that, there's a small ulcer or a tear. The typical presentation is patient would tell patient is scared to defecate. That's the presentation because of the severe pain. Even that pain lasts even about 15 minutes to half an hour or 1 hour, even after the defecation. And also patient has a history of constipation. Because the constipation, there's a tear and more pressure and fissure in ANO. Because of the pain, patient doesn't want to go to the toilet and try to hold the defecation. So again, constipation is a vicious cycle. Okay, commonly occurs in the young adults and working adults. Yes. Working adults and students, manual workers. Fissure is very common, especially in this weather condition. Very common, we'll see how to manage that one. So the anal fissure, it can be primary or secondary. Secondary in a sense, there should be a reason to develop that anal fissure. It can be Crohn's disease, TB, STDs, malignancies, or metastatic basal cell carcinoma, lymphoma, leukemia. Those are the secondary fissures. The appearance of fissure, maybe when you do DRE, you can identify the fissure with a small skin tag. If the skin tag is there, then it should be a chronic fissure. It can be an acute fissure or chronic fissure. Normally, it is in the 6 o'clock position because of the blood supply is minimal in the 6 and 12 o'clock position. So the common occurrence of acute fissures for the primary pathology in the 6 o'clock position. The fissure can be anywhere in the anal verge or multiple. In that case, we should think about secondary pathology. Okay. As I told you, there's a tear to the anoderm within the distal half of the anal canal, there should be severe pain with the passage of bowel movement, and pain lasts for about 30 minutes, even more after defecation. May be accompanied by bright rectal bleeding. Patient would complain after the defecation, drop of blood, or during the defecation, there's a streak of blood or coating of blood. Anyways, a fresh PR bleeding. The development of chronic fissure in for about 40% of the patient. So the problem here is there's a tear, the inoderm, it will expose the internal sphincter. So the exposed internal sphincter muscle within the bed of the fissure frequent spasm, which will not only contribute to severe pain, but also can restrict the blood flow to the fissure and also it's preventing the healing. Okay, that's also one reason one of the treatment modality is prescribing vasodilators. We'll see that. So less common causes of the minimal PR bleedings are the anyway again angiodysplasia, proctitis, polyps, and infectious gastroenteritis, colitis, coagulopathy. Your patient may be on blood thinners, radiation proctitis, solitary rectal ulcers, macrodiverticulum, and anorectal trauma. We should not forget that one. So trauma also can present like that. Diagnostic approach. This is important because say if a patient comes to PR bleeding to the general practice, whether this patient can be managed at the general practice level or OPD level, or this patient need to be escalated to the specialist. Okay, the secondary care center or tertiary care center, or to the consultant or the specialist clinic. Okay, history and physical examination. As we have discussed, history, yes, of course, they are in the blood, whether fresh or dark, altered, drops, mixed stool, coating the stool, how frequently, previous episodes, volume, okay, or any anal conditions, any past history of anal conditions, any past history of interventions, any past history of hemorrhoids, fissures, any documents. Okay, if it is in anal conditions, definitely fresh blood. If it is like rectal source of bleeding is in rectum, it should be fresh blood or darker, not many. Okay, maybe with some clots. Colon is also the same, fresh or dark. If the source of bleeding is more proximal, small bowel or duodenum, stomach, definitely it will coming with the patient present with the melena or fresh bleeding. In that case, it means there's a torrential bleeding inside. There are some red flag signs we should always ask to the patient, who the patient comes to the clinic or with the PR bleeding. Bowel habit. Is there any change in bowel habit? Any alteration in the bowel habit? Any passage of mucus towards, so alteration in a sense, rather than constipation, the colorectal carcinoma most of the time present is some sort of mucus passage because the tumor can produce lots of mucus and can present as diarrhea. So increased frequency, weight loss, anemia, or on examination any abdominal or rectal mass, and sense of inadequate evacuation, tenesmus. Those are some salient features we should always ask to the patient who comes to PR bleeding. So in that, if there are any one of these signs or symptoms, definitely that patient should be escalated to the specialist clinic. That patient is not a candidate to treat at the OPD level or at the GP level. And previous history and family history is very important. And you know, the colorectal carcinoma, the worrying part in PR bleeding is the colorectal carcinoma, nothing else other than that. All others are the benign pathology we can manage anytime. So the patient's concern or our concern also is also whether it's a carcinoma or not. Therefore, if the patient's having family history, irrespective of type of PR bleeding, that patient should always be escalated to the specialist for further investigation. So examination, DRE, digital rectal examination. It has two components. We should not forget that. It's an external inspection of the anus and perineal region, and then digital rectal examination, right? You know, for an adult index finger, normally it's about 7 to 8 centimeter long length, okay? Even sometimes more than that. If you do a DRE properly, we can at least feel 8 centimeter from the anal verge. Okay, we know the anus is about 2 to 3 centimeter, and rectum is about 12 to 15 centimeter. So if we can do proper DRE, we can palpate at least 8 centimeter from the anal verge. It goes beyond the maybe at the level of the lower part of this mid rectum, right? So we should not forget to do DRE. Any patient comes with the PR bleeding. Okay, there are various number of cases. Missing DRE will end up with missing some cancers. And the other thing is proctoscope. Proctoscope is not commonly used after the DRE or after when the patient presents PR bleeding, but we should not forget that one. It also can inspect the anus and rectum, and it's the best investigation of choice to see the hemorrhoid. Okay, even sometimes more than 6 endoscopies. Endoscopy in a sense, sigmoidoscopy, so colonoscopy. The proctoscopy is the best investigation of choice to see the hemorrhoids. Okay, and sigmoidoscopy. When to do sigmoidoscopy? Okay, fine. When to escalate the patient for endoscopy if a patient comes with PR bleeding? That's a real question, because patients come with PR bleeding, whether treat or as an outpatient, or send the patient to specialist clinic, or this patient need endoscopy. It's a really always it's a dilemma. Okay, so when to escalate the patient for a specialist center or for an endoscopy if a patient presents with PR bleeding? Remember, if a patient, that patient has no any family history or any past medical histories, in a sense associated with any bowel cancers or anything. If the patient is less than 45 years old with fresh PR bleeding, okay, DRE and sigmoidoscopy is sufficient. Okay, if the patient is having less than 45 years old patient, PR bleeding, and if you can't find any anal pathology in the DRE, right, that is 90% is enough. Okay, even sometimes no need to go for any endoscopy. But as I told you earlier, the hemorrhoid or any perianal condition does not exclude the proximal pathology, right? So sigmoidoscopy is advisable for such cases to see the anus, rectum, and sigmoid. Oh, basically we should see the rectum. But when to do colonoscopy for a patient? This is important. Anorectal source of bleeding is not found at the initial evaluation. Patient comes to PR bleeding, we couldn't find fissures or anything, or bleeding piles or lumps at the anal verge. DRE also we couldn't find anything. So that patient need to go for colonoscopy. Second thing is age equal or more than 45 years. Reason, chance of developing colorectal carcinoma is more towards advancing age. Third one is symptoms with iron deficiency anemia. Fourth one, risk factors for colorectal carcinoma. Irrespective of age, irrespective of the PR bleeding or type or volume or fresh or altered or whatever it is, the patient has a red flag signs, or if the patient has a family history, that patient better to be referred to a specialist center or specialist to go for endoscopy. What is about the CT and MRI angiogram? Yes, it's also one of the maybe one of the commonest investigation of choice in the UK, where the patient comes with PR bleeding, straight away at the A&E they order for the CT angiogram, and it's a refined and imaging, but to identify the source of bleeding for the CT or MRI angiogram, that source should bleed at the time of taking that picture. Okay, so that is a bit of a fine investigation. We leave that, and we gone through proctoscopy, sigmoidoscopy, and colonoscopy. What is this CT colography? Do we need to go for CT colography for all patients? No, it's not indicated for as an initial investigation for all patients. Some candidates, they are not tolerating colonoscopy. Frail patients, or patients are contraindicated to preparation of the bowel or colonoscopy, then of course we can go for CT colography. not for the all patients. And also we have heard about something called barium enema. It has no role with rectal bleeding. There's no choice of investigation as such for rectal bleeding, barium enema. Okay? There's not practice anymore for in terms of PR bleeding. Like, what also I'm putting something different slide here, and I'll tell you why. This is the statistics in our country, the instance of malignancies. We can see here, the first column, males have the third common cause is colorectal carcinoma. In female, that is fourth. So still, colorectal carcinoma plays a vital role, patients' morbidity and mortality in male or female in our country. Okay, right. I will quickly go through the colorectal cancer screening. I'll tell you why later. Okay. Screening program is not well established in our country, but in the UK, every individual equal or more than 50-year-old age is a candidate for the bowel cancer screening. The age limit was 54 until 2021, and now the age limit is reduced up to 50. From 2021 onwards, it's the 50. So 50th birthday or few days after, in the UK, they will receive the patient, the person will receive a mail containing a kit that is called FIT kit. Okay, fecal immunochemical test. It's a type of test. Patient will receive the kit. What to do with that kit? Patient has all the in detail, everything is mentioned, what to do, how to collect, and how to send. So patient will collect the sample of poo and send it via the mail again. And patient will receive a report in 2 weeks' time. It's normal or patient need for the investigation. Okay, there's one type of bowel cancer screening program in the UK, but not well developed or established in our country, unfortunately. So the cancer screening can be two types. One is a stool-based test. If it is positive, we can escalate for endoscopy. Second is a direct visualization by endoscopy. There are two types of stool-based test. One is a FIT test, and the other one is a FOB, fecal occult blood. Okay, FIT test is directly measures the hemoglobin in the stool. It means if there's a source of bleeding, it will show positive. That's all. And it doesn't show where the bleeding is, what type of bleeding, and what the pathology behavior. Why I'm telling is here, if a patient presented or the past history of 1 month back, patient had a history of PR bleeding, or now patient present with PR bleeding, do we need to order for the FIT test or a fecal occult blood? No. So I have seen in some places, they still order for investigation of fecal occult blood. No, because fecal occult blood is to see unseen blood. We don't know the patient bleeding or not inside, but to see if there any bleeding source, we do the fecal occult blood, the FIT test. Remember, FIT test is available here. It will cost about 4,500 or 5,000 rupees if you do an outside, if the FIT test. So if the patient has a history or had the history of PR bleeding, no point of ordering the FIT test or the fecal occult blood test, because obviously the patient had a bleeding. It's like patient had a history of hematuria, and what's the point of doing the UFR, urine flow report to see the blood cells in the urine? That's the same thing here, right? Right. So no need to do FIT test or fecal occult blood test ordering for the patient coming with the PR bleeding. Anyway, it will be positive then, okay? PR bleeding or the past history of PR bleeding, right? Treatment options. Okay? Treatment depends on underlying cause. If the hemorrhoid, okay, fine, it's a first degree, second-degree hemorrhoid, and no sinister pathology, no family history, or any other associated symptoms, definitely we can manage the first and second-degree hemorrhoid. We can manage topical treatments, oral fluid intakes, stool softeners, high-fiber diets, and neither we can manage 4 to 6 weeks. If fails, we can escalate to the special center. For the first and second-degree hemorrhoids, as an outpatient, there's a procedure called rubber band ligation. It can be done as an outpatient. It's a success rate was not that good, but still it's well recommended treatment modality. Okay, and there may be need of repeat procedure within 6 months as well. Okay. Another one is a Doppler guided hemorrhoid lateral ligation, but still the gold standard procedure is the open hemorrhoidectomy. Okay, so fresh PR bleeding, and it has no risk factors, manage outpatient, and first degree, second degree hemorrhoid, and manage outpatient, and if it is failing, escalate to a specialist center. Anal fissures is the same. Dietary advice, bulking agents, tools of nurses. And always, but we should try with medical treatment for the anal fissures. Better not to go ahead straight away to the surgical intervention. And medical treatment also is very tricky, young patients, and it will not heal overnight. It will take at least 6 weeks to 8 weeks. So we should clearly tell the patient, applying GTN, local application, in a proper manner, not outside the anal verge. We have to apply slightly inside at the level of the internal sphincter. It's very difficult application. And we should tell everyday patient should apply, and it will take at least 4 to 6 weeks to heal, right? And the other important thing is botulinum toxin, Botox. It is practiced in the Western world. It's a very nice treatment modalities, 2 to 10 units of botulinum toxin injecting all quadrants and over the 2 quadrants and left and right. It will definitely and quickly relax anal sphincter, and wound will heal in about 3-4 weeks time. Okay. In refractory cases, definitely we should go for lateral internal sphincterotomy. Okay. It has pros and cons and contraindications and chance of developing flatus incontinence, chance of developing fecal incontinence. Better avoid in multiparous women and elderly women, because already their internal sphincter and the sphincter complex is weak. If we do the sphincterotomy, we are not going to do the sphincterotomy in a sense, the full sphincterotomy. We should do the part of sphincter up to the level of the sphincters. So if you do sphincterotomy, already the patients have weak sphincter, then definitely the patient will end up with incontinence. The MAD, manual anal dilatation procedure, is also called DOT procedure. It is actually practiced several years ago. That is not done, and that is not indicated. It will cause lots of complications. And the inflammatory bowel disease, colorectal cancers, diabetic disease, those are the specialist management and specialized management. It should be managed in the specialist center, not in the as an outpatient or in the GP level. When to seek medical attention, and persistent bleeding, family histories over the age of 50, definitely patient should go to the doctor. They can't just avoid that one, ignore it. So any patient with PR bleeding, if they are in the following criteria, they should definitely be referred to the specialist center or the secondary care or tertiary care. Age more than 40 years with a fresh PR bleeding, and frequencies for about 6 weeks with mucus or any loose stools and some sensitive approach. Second one is age more than 60 years, rectal bleeding, yes, rectal bleeding for 4 to 6 weeks, but no any other pathology, still that patient should be referred. So now we see the cases again. We will go back, okay? First thing, 23 years old pregnant mother, PO is 30 weeks, presenting with fresh PR bleeding. We all know pregnant mothers have the high tendency of developing hemorrhoids, right? After the delivery, it will be all right, disappear of the hemorrhoid, and then second pregnancy, third pregnancy, again the patient will develop the hemorrhoid. That we know. So here it's the same scenario. 23-year-old mother, pregnancy, fresh PR bleeding, on and off, and no any other associated symptoms. On inspection, there's a 3rd-degree hemorrhoid. Right, fine. So straight away, so obvious, okay, fine, we leave that patient and we manage for the hemorrhoid. No, the missing part is doing DR. Even though it's an obvious hemorrhoid, we should always do a DRE and to make sure nothing is inside. At least we can't go for an endoscopy. We can do endoscopy if that's since the pathology of the family is a different story, but we should not excuse for DRE. I know this is difficult to position the patient, difficult to the very uncomfortable with the pregnant patient as well as the DR positioning and everything, but we should, because there are instances happen. Pregnant mothers come with a hemorrhoid, and managed as a hemorrhoid again and again and again, and after a while found to have an invasive rectal carcinoma. So here the highlighting point is never forget to do DRE for any PR bleeding patient, right? Second, 30-year-old manual worker, minimal first PR bleeding for 2 months, blood drops at the end of the defecation, no pain, no family history, CRC. DRE is normal. I told you, 30 years, no any other sinister pathology, fresh PR bleeding, and DR is normal. It means maybe first or second degree hemorrhoid. In first or second degree hemorrhoid, we can feel it, and no pain, so there's no fissure. Do we need to go for endoscopy? Better if you can do at least proctoscopy. We can see the hemorrhoid. Okay, flex 6 identical, but go for a proctoscopy. And third one, 25-year-old girl student, is a student presenting with minimal PR bleeding, unbearable pain associated with defecation. Pain lasts for about 30 minutes after defecation. Blood drops after defecation, or streaking blood, or reporting the blood, and no family histories. Needed DRE? Yes, but doing DRE, because by history, we know that this is a fissure in anal. Doing DRE to an anal fissure patient is difficult. Already patients in pain, and the sphincters are spasm and tight anal sphincter, and doing a DR is very tricky and difficult. So we can, with the proper discussion with the patient, we can proceed, or better not to proceed. Doing the endoscopy, most probably not. Endoscopy and proctoscopy is flexi or colonoscopy. Okay. The fourth one, 56-year-old male patient presenting with fresh PRB second episode. First episode was 2 months ago. Blood mixed with stool. No any other symptoms. DR is normal. No blood thinners. What is next one? It's 56 years, over 50, over 45 years, fresh PR bleeding. DR is normal because any first and second degree we can feel it. And up to the lower part of the rectum also we can, it's normal, it's a DRE. We don't know the upper part of the rectum. No blood thinness. Do we need to do anything? Definitely we should, this is a candidate for colonoscopy. Okay, because of the age. 67 years old patient, PR bleeding, fresh bleeding, mixed stool, also complaining of weight loss and some inadequate evacuations. And also patients having third degree hemorrhoid, that's a different story. Okay, patient has the sinister symptoms, red flag signs, but also having the third degree hemorrhoid. Forget about the hemorrhoid. Patient is a candidate for the colonoscopy. Right, 30-year-old female, one of loose stool with blood passage, 4 weeks or for more, associated with low abdominal pain, weight loss, and also has a sibling maybe having the same history and being treated in the clinic. DR is normal. What is this? Most towards inflammatory bowel disease. This patient need a specialist management, should be escalated to specialist center for further investigation and diagnosis and treatment. And so the take-home message, if any patient, irrespective of the age, any complaint, fresh or dark or altered blood, always do DR. We should not, there's no excuse not to do DR, right? Second thing is, age more than 40 years, with rectal bleeding, with change of bowel habits towards loose stools or more frequent stools for more than 4, 5, 6 weeks, this patient need to be escalated always. It cannot be managed at the GP level or OP level. If a patient more than 60 years of age, PR bleeding, that's it. Patient should be escalated. Whether the patient is having sinister pathology or any other pathology or not, the patient has or not, that we had to refer to the specialist center. So a patient with a large fresh bleeding, torrential bleeding, hemodynamic unstable, we should not forget the upper GI bleeding. The patient is a candidate for the OGD and colonoscopy. Thank you. We can go for questions and answers, please. Anything you want to ask?
Okay, so thank you so much for that very informative lecture. So first we will like to move on to the questions which are in the chat right now. So Dr. K.A.S. Chintan has asked, what are the common causes for proctalgia in younger patients? We would like to know about that.
Yes, basically proctalgia younger patients in what is the age of the patient? Young is 50 years old for a young patient in foreign countries, 55 years old a young patient. But anyway, for the young patient, very common one is some infection. Okay, the patient is presenting with what you call proctitis, is a transient, and presentation may be hours or days or weeks. is a common one, is an infection in our country.
All right, so thank you, sir. And he also wants to know, is high protein diet a risk factor for IBD?
IBD, high protein diet is not a risk factor at all. Okay, it's a risk factor for the IBD is a different discussion, but high protein diet is not a risk factor for the IBD. There's no such proven statistics so far regarding the high protein diet.
All right, so thank you. So, and also Dr. Syamadeen has come up with a case scenario actually for a healthy asymptomatic patient with a strong family history of colon cancer and ovarian cancer and negative fetal occult blood test. What is the ideal age to perform colonoscopy to screen for signs of carcinoma of the colon? So lots of other participants have also asked about the screening protocols. So would you like to comment on that?
Of course. The fecal occult blood test is actually speaking the sensitivity, not like as FIT test, FIT, fecal immunochemical test. There's lots of false positives, lots of false negatives for the fecal occult blood test. Fecal occult blood test is a what do you call? It's a random test. It should be done in a proper way. There should be a 3 consequent samples should be taken to go for fecal occult blood. Fine. If it is negative, it will not exclude the malignancy behind. The problem here is patient is having colorectal carcinoma family history and ovarian carcinoma. We should not think about the fecal occult blood for this patient at all. Okay, this candidate is always ideal candidate for a colonoscopy from the age of 40. And even before we can do that one, but from the age of 40, normally the screening program starts 50 years of age. And in the Western world, we don't do here, but 50 is a, what do you call, the age limit. But here, we don't do that one. But if the patient's having the family history and ovarian CA and colon CA, there's no talk about the fecal occult blood. The patient is a candidate for the full length of colonoscopy from the age of 40.
Okay, sir. Thank you. And some of the participants have would like to request information about this fetal immunochemical test, the FIT test, and also the DNA FIT test, which is available in the Western world. They want to know whether it's available in Sri Lanka, at least at the private sector, or
yeah. FIT test is available everywhere, and I don't know whether it is done in the government sectors. In the private sectors, it is there, and it will cost about. That one kit is 4,500 rupees at least. The normal is it's a range 4,500 to 7,000 rupees. That one kit is 4,500 rupees. It is available.
Yes, and thank you, sir. And also about the screening in adults in Sri Lanka with a person with a likelihood of like an average risk. So what would be like the recommended age for screening and the continuity of it? So because we still don't have any guidelines, or are there any places guidelines? Yeah.
That's true. Because the colorectal carcinoma is not a very common as carcinoma in Sri Lanka. It is in the male for third place and female for 4th place. But not like in the Western world. Western world is one of the commonest presentation because all the complication develops earlier. So they have established the guideline to go with the 50 years of age for the screening program. But even though there's a high risk of developing colorectal carcinoma, the screening program starts in 50 years. So in our country, I don't think it is the establishment of screening before 50 years. 50 years is 50 for our country also, the normal we can screen for the patients for colorectal carcinoma, not before that.
All right, so thank you. And also a little bit about the pediatric presentations. Some of them, Dr. KMS Pereira wants to know, for the child presented with constipation and PR bleeding, do we need to conduct a direct rectal examination, digital rectal examination?
It depends, right? Depends on the patient, especially patients, parents, or who are accompanying the kid. Very sensitive issue, especially the female kids, and better if we can perform. If a child is very small kid, better not to perform. We should not hurt the child, and we should not, more than the child, we should not hurt the parents. In that case, the patient should be referred to the specialist center, And after the long discussion, we can do the DRE with our little finger and well application of liquid gel. Or we can straight away, we can treat the patient and we can leisurely, we can go for endoscopy and sedation.
All
But
right, so thank you.
we can do, but not like in adults, right?
Yes.
Kids, yes.
Okay, so thank you. And so one last question to wind up, sir. Dr. Ashinka Pushpakumar has come up with like a case scenario. A 47-year-old male diagnosed with small bowel oozing, but no specific bleeding point identified. So he wants to know, is there a specific management for a patient who comes with a presentation like that?
Yes. How do we, first of all, how do you know that patient is oozing from small bowel, right? So it is a guessing, right? So in a sense, the patient is presenting with maybe an acute low GI bleeding, torrential bleeding, and we do the OGD colonoscopy, both are normal. In that case, there's one possibility of doing the enteroscopy. But more than that, the CT angiogram, the MR angiogram will show where the bleeding is, which vessel is bleeding, okay, which mesenteric vessel is bleeding, and then we can go for a intervention. So the angiogram is the best choice of management for that patient, but it's an exclusion after the upper GI and lower GI bleeding.
So, okay, so we have received so many questions. So some of the questions will be directed to you through the email, and then you'll be answering. And
yes.
Yeah. And so thank you so much, Dr. So thank you so much, Dr. Shamugana and Swarnan, taking your time to be with us today and taking your time to share this knowledge with us, all of us today. And so today we discussed about the unveiling the mystery of understanding for reading and what you need to know. So on behalf of Shri, I would like to thank Dr. Consultant General Surgeon from this hospital, Balawanchikuri, for his excellent lecture and for the precious time shared with conducting the CPD session with Shri, the Society for Health Research. Thank you. And finally, a little reminder. Yeah. And finally, a little reminder for all of you, and thank you for chat box for the session at the end of the CPD. So please kindly give your feedback and answer assessment questions in order to resolve the participants and 50 pounds time. So we would like to indicate that we not have capacity to issue is more than 100 per day. Will not be receiving your e-certificates today. So if you do not receive your e-certificates today, please wait and see. You'll be reading it in the next couple of days. And if you haven't received certificate by this Friday, please thank you for joining me and wish you all a wonderful day. I'm hoping to be in another CPD session, right? Winding. That's what I was saying. Okay, have a good day.